All right, well, we might get started. So my name's Anthony KJ Smith. I'm a research associate at the Centre for Social Research and Health. It's my pleasure to introduce today's CSRH SPRC seminar series. So I'll just do some housekeeping before I introduce our excellent speaker. So just as some housekeeping, you can see we've got the recorder on, and just be mindful as well in terms of chat if you're directly messaging people. I'm not quite sure about how that works in terms of privacy, but if you're going to share anything salacious, maybe be a bit careful about that. And also, yeah, the session will be going for about 50 minutes, and there will be some opportunity for Q&A. So you could either put that in chat or just have your hand up ready towards the end when we do the Q&A. And I'd also like to acknowledge the traditional custodians. So I'm on Noongar Whadjuk Budja in Boorloo or Perth, and you're welcome to put the country you're on in chat. But yeah, it's my pleasure to acknowledge the elders past and present, and to acknowledge that sovereignty was never ceded. So it's my pleasure to introduce Sarah Calabrese with the title Addressing Inequities and Enhancing Patient-Provider Communication in the Era of HIV Biomedical Prevention. So Sarah is an associate professor in the Department of Psychological and Brain Sciences and the Department of Prevention and Community Health at George Washington University in Washington, DC. She's currently a visiting scholar at the Centre for Social Research in Health here at the University of New South Wales. She earned a PhD in psychology from the George Washington University and completed a postdoctoral fellowship at the Yale Center for Interdisciplinary Research on AIDS at Yale. Broadly speaking, her research focuses on stigma, sexual health, HIV prevention, and healthcare inequity, and much of her work aims to identify and address barriers to biomedical prevention resources and knowledge among marginalized groups. So it's my great pleasure to introduce Sarah today. I drew on a lot of her work in my PhD, so it's been really exciting to have her visiting at the center. So I'll hand over to Sarah.
Thank you, Anthony. Let me go ahead and share my screen. Okay, are you seeing it okay? Okay, perfect. Great, well, thank you again for the introduction, Anthony, and to the Center for Social Research and Health for inviting me to speak today and for hosting me as a visiting scholar this semester. I too would like to acknowledge the, in this case, Bidjigal people that are the traditional custodians of this land, and pay my respects to the elders, both past and present, as well as extend that respect to other Aboriginal and Torres Strait Islanders who are present on the call today. So here's the plan for what I'll be covering in today's talk. I want to start by giving a very brief background on HIV and biomedical prevention. I imagine a lot of those who are on the call are already experts in this matter, but I do want to make sure that everyone has at least a baseline level of knowledge. Then I'll get into inequities, challenges, and opportunities related to patient-provider communication dynamics in the current biomedical era. And I'll be drawing on examples from my own work, most of which has been with US providers. However, I also want to share some preliminary insights from the research that I'm currently conducting here in Australia. So I'll be sharing that towards the end and then discussing implications. So beginning with the bigger picture, it's been over 40 years since the earliest cases of HIV began to emerge, and yet HIV continues to impact many people around the world. So there are over 38 million people living with HIV, and about 1.5 new HIV infections globally every year, as well as 650,000 AIDS-related deaths. Here you can see an overview of the Australian and US epidemics. You can see the relative numbers. Of course, there are many more people living with HIV and new infections in the US every year, but it's also a much larger overall population. The epidemics are similar in a number of ways, in that the HIV prevalence is far less than 1% in the general public. The majority of new infections occur among men who have sex with men, or MSM. So I think the most recent numbers are about 68% in Australia and about 71% in the US. So although a cure or vaccine for HIV remains elusive, there are highly effective prescription-based medications that are available to prevent and treat HIV. And so I just want to highlight those here because that's what this presentation will be focusing on. So there's PrEP, or pre-exposure prophylaxis, and that's medication taken by people who are HIV negative to prevent HIV. It's over 99% effective in daily pill form. There are other dosing strategies, such as taking pills around the time of an event, and modalities such as injectables or implantables that are at various phases of testing, development, approval, and availability. And undetectable equals untransmittable, or treatment as prevention, as it's sometimes known. So this refers to the scientific conclusion that people with HIV who maintain an undetectable viral load cannot sexually transmit HIV. So I highlight this as one of the kind of relatively new, as in the past 5 to 10 years, advances that HIV science has brought, which has a profound impact on the lives of people living with HIV as well as the broader community. The other background that I want to share is just to acknowledge the very significant disparities in access to HIV biomedical prevention. Looking in particular at the US, patterns of PrEP uptake really do not match patterns of HIV infection. So in particular, when we're looking at race, PrEP uptake is disproportionately low among Black and Latinx people, as well as other key groups. So as you can see in these pie charts, Black and Latinx people make up about 69% of new HIV infections when you look at them combined, but only 24% of PrEP users. So there are significant inequities in access to PrEP. So with that in mind, I want to segue into presenting a study in which I did focus groups with Black sexual minority men who are a key population in the US, disproportionately affected by HIV, as well as community healthcare providers to discuss patient-provider communication. So patient-provider communication is a key factor affecting PrEP awareness and access. Black sexual minority men are less likely than white sexual minority men to have discussed PrEP with a provider or to have initiated PrEP after discussing it with a provider. So given that that's the case, clearly a more nuanced understanding of communication dynamics between Black sexual minority men and healthcare providers would be beneficial in terms of figuring out how to optimize those conversations and thereby facilitate future PrEP uptake and engagement among Black sexual minority men. So the particular objective of this study was to explore HIV negative and status unknown Black sexual minority men, as well as community healthcare providers' views on patient-provider communication related to PrEP and sexual health. So here you can see the methods of the study. So we conducted 11 60 to 90-minute focus groups with a total of 63 participants. These were held in the northeastern US. I've split the two sets of participants. So altogether we had 36 Black sexual minority men who, in addition to identifying as Black and identifying as men, they needed to be cisgender men, HIV negative or status unknown, and sexually active with a man in the past 12 months. Among providers, the criteria were pretty broad. We didn't require that they had any experience prescribing PrEP. In fact, we didn't necessarily want everyone to have experience prescribing PrEP given the goals of the study, but there was a requirement that they were licensed to prescribe medication. Okay, so as far as background characteristics, you can get a sense of our Black sexual minority male sample here. So the majority were non-Latino, most were born in the US, most identified as gay or bisexual. The vast majority believe their status to be negative, and most had heard about PrEP prior to learning about the study. Here are some characteristics of the healthcare providers. It's a little more detailed because I don't just have sociodemographics, I also have some of their professional characteristics. So this group was predominantly female, predominantly white and non-Latinx. Most were heterosexual. The vast majority had nursing degrees and were practicing in primary care. In fact, all of the focus groups that we did were in healthcare, community healthcare settings. Most were previously aware of PrEP, but only a minority had ever discussed PrEP with a patient or prescribed PrEP. So this slide summarizes the themes that emerge from these focus groups. So there are both points of alignment and divergence in terms of the perspectives of the two groups regarding communication about PrEP and sexual health. So what the two groups were aligned on is the importance that they ascribe to maximizing patients' comfort, as well as their belief in patients' right to non-discriminatory healthcare. But where they diverged was in Black sexual minority men's preference for sexual privacy compared with healthcare providers' expectations around information sharing. The perception that healthcare providers had an ethical responsibility to initiate conversations about PrEP. That was the viewpoint of Black sexual minority men, whereas healthcare providers very much saw it as optional. And Black sexual minority men also had a preference for personalized conversations about sex, whereas although views were mixed, the majority of healthcare providers really appreciated having more standardized tools to rely on, such as checklists and scripts to guide those conversations. So delving into those themes a little bit more, when it comes to that first theme, that first point of alignment related to patient comfort. So both groups identified similar environmental and interpersonal strategies that fostered comfort. So that included physical cues like rainbow flags or pins, use of sensitive and affirming language, and also asking permission to inquire about sexual histories. And both groups also recognized that patient comfort coincided with patient-provider rapport, which was built over time. So this quote is from one of our Black sexual minority male participants, and I want to note that quotes that are shown in yellow are from the patient perspective, those in blue are from the provider perspective. So this patient said, I've been getting comfortable with talking to, like I said, I went to the clinic, when I got my test last week. It took me a couple of years to sit here and, when they asked that question, do you have sex with guys or girls and, oral? At first I was like, I really feel uncomfortable answering this question, but now with them, it's like, yeah, this, that, boom, bang. With respect to the second point of alignment, which was belief in patients' right to non-discriminatory healthcare. So both Black sexual minority men and providers valued culturally competent sexual healthcare, mutually endorsing the attitude that marginalized patients were entitled to fair and equitable treatment. However, this value really conflicted with the actual experience of a lot of the patients, as well as several providers' choice of language and shared anecdotes, which suggested that they may not be fully attuned to their own biases. So these quotes are from providers. The first one is from a provider who said, any male who admits or discloses that they're having sex with another male, you can tell just by the choice of language that there is some judgment in that quote. And then in the second quote, that provider said, in the real world, as a provider, I don't think anybody has a prejudice or a bias against a specific color or race. Which really conveys a certain level of naivete. When it came to points of divergence, so providers and patients expressed inconsistent views around patient sharing of information about their sexuality. So many Black sexual minority men questioned the necessity of reporting same-sex behavior or sexual minority identity. So this patient said, if it's not a gay drug for gay people, you shouldn't have to be like, oh, I'm having sex with men in order to have this drug. I don't feel like you had to necessarily go into your sexuality in order to reference that you need the drug, as if HIV is a gay disease. You shouldn't have to tell your doctor if you're sleeping with men. If you're having sex, you're at risk for HIV. Black sexual minority men also expressed concern that expected information sharing could deter people from seeking care, and also it could lead to mistreatment by healthcare providers. By contrast, providers generally regarded sexual history reporting as germane to their ability to provide optimal healthcare. So in this quote, the provider said, "If you disclose all the information to me, that's the only way that I can really help you." With respect to the second point of divergence, Black sexual minority men were nearly unanimous in the opinion that the onus to initiate conversations about PrEP should be on the provider rather than the patient. And he saw it as the responsibility of the provider. So this particular patient said, most people don't know about most things, so providers should bring it up. They should talk to everybody. Your healthcare provider is someone, like, when you hear it, they can take away stigma from most medical things. Black sexual minority participants' preference contrasted with the actual experience of most. So if they had discussed PrEP with a provider at all, they reported that they had to be the ones to broach the topic, not their providers. Over 3/4 of providers had never previously discussed PrEP with a patient, besides the fact that most were aware of it. And among those who had, several reported that their patients typically initiated the conversation. So that was actually consistent with the experience of our patients. So this provider said it was very easy to prescribe to the first patient because he was so educated about it and really wanted it. So I had no problem with it at all. I've never had the conversation with someone just to suggest it, so I'm sure that would be maybe a little more difficult. Some providers reported reservations about initiating conversations about PrEP because they lacked familiarity with PrEP or because they were unconvinced of its safety and efficacy based on their understanding of the scientific evidence, or lack thereof, lack of understanding, that is. Okay, and then the third point of divergence had to do with communication style. So many Black sexual minority men emphasized the importance of a personalized, two-way conversational approach that fostered the sense that the provider really cared about them and was invested in their well-being. So this patient said, you always have to be genuine because people can see when you're doing your job and you're just like, you have sex with men, okay, you know what I'm saying? Just going down the checklist. If you can actually like look someone in the face, like, and just talk to them and try to have a conversation with them instead of like doctor and patient. Let's be a person to person and have a genuine conversation and see if I can get you to open up a little bit more. And then, you know what I'm saying? We'll be like, okay, well, I met this guy, I'm doing this guy, I'm doing this guy, I need some condoms and I need PrEP too. And some men felt as though a provider's reliance on standardized tools to guide the conversation felt dismissive, not only of their experiences, but also of their own knowledge on the topic. So in other words, by using this kind of standard form for all patients, the provider was neglecting to assess the patient's existing knowledge and tailor the conversation accordingly. And then by contrast, most providers favored the use of standardized tools, suggesting that they facilitated the efficiency that was needed in a busy healthcare setting. And providers also found checklists and other tools to ensure that content was covered. So to make sure that they covered everything that they wanted to cover and that they were using appropriate language to broach sensitive topics. So this provider said, especially the ones that are bisexual or homosexual, how do you talk to them? How do you explain to them? And how do you get them to talk to you? How do you ask those right questions and get some information? So again, really wanting some scripted guidance about how to talk about sensitive topics. Providers also suggested that standard forms and questions could be reassuring to patients. This provider said, you know, because they, meaning the patients, start looking at me like, why are you asking me these questions? It's in the form. I just have to do it, so just tell me. Okay, so that's that's a description of some of the qualitative work that I've done. And I want to turn now to a series of quantitative surveys that I've conducted that have really delved into provider biases in the provision of PrEP. So some of the early research I did was with medical students, and this was surveys and vignette-based experiments that collectively indicated the potential for provider biases to interfere with PrEP clinical decision-making. So the form that this took was medical students were presented with a clinical vignette, in other words, a little story about a hypothetical patient. The patient was a male patient seeking PrEP who had a male partner with HIV. And we systematically manipulated whether the patient was described as a Black patient or a white patient. And so in the first study that we did, we found that patient race was indirectly related to PrEP provision, meaning that those participants who read about a Black patient, the Black patient was judged to be more likely to increase sexual risk-taking if prescribed PrEP, and that was associated with a lower willingness to prescribe PrEP. In a subsequent study, we did not see the same race effect. We did see that sexual prejudice was indirectly related to PrEP provision. So the vignette was about a sexual minority male patient seeking PrEP. And what we saw was that medical students who reported more negative attitudes towards sexual minorities anticipated greater sexual risk compensation. In other words, thought that the patient would engage in more sexual risk-taking behavior if prescribed PrEP. They also predicted poor adherence. And these two judgments were associated with a lower intention to prescribe PrEP to the hypothetical patient. We also saw some biases related to condom use and relationship status. So in this particular study, whereas other ones, were kind of a between subjects design, this was actually within subjects, meaning that the same participant was presented with 6 different kind of scenarios side by side and were reporting their willingness to prescribe in each scenario. And so these scenarios varied by both condom use as well as patient relationship status. So the condom use manipulation, so the participant was either described as using condoms and intending to continue using condoms if prescribed PrEP. That's sustained condom use. The sustained non-use condition, so that's when the participant or the patient was described as not using condoms and intending to continue not using condoms if prescribed PrEP. And then planned discontinuation was a condition in which the patient was using condoms and intended to discontinue condom use with PrEP. And so what we saw is that participants were more willing to prescribe to MSM the male patient who planned to continue using condoms versus discontinue use or continue not using. And participants were more willing to prescribe to monogamous sexual minority men compared with MSM with multiple partners for 2 of those 3 conditions. And so, what's striking about these findings, besides the fact that it was within subjects, so participants actually saw all of these scenarios side by side and made these judgments. But, if you think about who's at greatest risk, their willingness to prescribe is actually paradoxical to patient risk. Likewise, in the same study, we asked about which of the following reasons, if any, are acceptable reasons for a male patient to stop using condoms while on PrEP. And so what you can see in the yellow column was the percent reporting that each reason was acceptable. So keep in mind that any of these reasons for discontinuing condoms confer the same level of risk. Participants were much more accepting of conception as a reason than emotional connection, pleasure, or sexual functioning. And clearly for a man who only has sex with men, that is the one reason that wouldn't be relevant. So this was concerning as well. So that was some of the early research we did, but all of that was with medical students. So we then did a study with practicing healthcare providers. And so with these, we were interested, we wanted to look at race again, but we were also interested in bias related to patient injection drug use. So just in the way of background on that, there has been research establishing that PrEP is beneficial for people who use drugs. In the US guidelines, it's been recommended for, almost as long as for sex. And despite that being the case, providers have consistently reported lower prescription rates for this group compared with groups at risk because of sex. And even in looking at 2021, a study published in 2021, the recent data at that point showed that only a quarter of US people who inject drugs were aware of PrEP, and less than 1% had used PrEP in the past year. So it's very underutilized. And the objective of this study was to examine how patient risk behavior, as well as race, affected providers' PrEP-related clinical judgments, and then to look at various clinical judgments as mediating mechanisms of the association between those patient characteristics and intention to prescribe PrEP. So similar to what we looked at with medical students. So this study, rather than doing a vignette, we instead presented participants with a mock medical chart. So this was a national online survey of HIV and primary care providers. And in that survey, participants were given background information about HIV as well as about PrEP. So they were alerted to the risk of infection related to injection drug use. And they were also informed that PrEP was recommended for prescription to people who inject drugs, among other groups. We then asked the participants to review this mock medical chart, this kind of fictitious medical record. And then we had them report clinical judgments and perceptions about the patient described in the chart, including their intention to prescribe PrEP for him. And I say him, in all of the scenarios, the patient was described as a man. So it was a 2x3 between subjects design, for those of you who are scientists on the call. So the race that we manipulated was either a Black patient or a white patient. And then risk, it was either a man who has sex with men, a man who has sex with women, which I'm abbreviating here as MSW, or a man who injects drugs, which I'll be abbreviating as MID. And so just zooming in on the medical chart to give you a sense of how we manipulated. So with race, we manipulated, it was actually, just a checkbox as well as by the patient's first name. So we used names that were common among white Americans and names that were common among Black Americans as first names. To manipulate the social and behavioral history, you can see here, this is the chart from the man who injects drugs. So this person had no sexual partners, but was described as injecting heroin at least once a day, reporting sometimes sharing needles with a partner who has HIV, and that partner has declined HIV treatment. So, objectively, this is somebody who's at very high risk. Here you can see the MSM condition. So the MSM patient was not using any kind of intravenous drugs. He was described as having a male sexual partner who, again, was positive and had declined treatment. He was reported to have inconsistent condom use and anal sex at least 3 times a week. And then the MSW condition, the man who has sex with women, was analogous to this one, except that the patient's partner was described as a woman, and the type of sex was described as vaginal rather than anal. So here are the sample characteristics. So just to summarize, the majority of these practicing providers were white. They were predominantly heterosexual. They were recruited throughout the US, and the majority were physicians. In terms of kind of relevant experience, all had experience caring for the different patient types described, or nearly all, above 96% had experience caring for a man who has sex with men, a man who has sex with women, and a man who injects drugs. And quite a few had experience discussing PrEP with patients and prescribing. So for those of you who are interested in stats, I'm presenting the stats. For those of you who are not, there's a bullet point at the bottom of the slide there that's just kind of explaining what these stats say. And basically what we found is that there was a significant risk effect, meaning that judgments varied depending on whether the patient was described as a man who injects drugs, a man who has sex with men, or a man who has sex with women. There was no significant race effect or race times risk interaction effect. So this slide shows pairwise comparisons across risk groups for individual clinical judgments. So the different letters indicate significant mean differences between two groups. So for example, if we were to look at HIV risk, we can see, because the letters are all different, that they are significantly, the three groups are significantly different from one another, with the man who injects drugs judged to be at highest risk for HIV. And so what you can see when you look across these bars is essentially that the man who has injection-related risk was perceived to, again, be at higher risk for HIV compared with the other two groups, but he was also perceived as less likely to adhere to PrEP, less safety conscious, and less responsible. And so this shows a multiple mediation model where we were looking at the different clinical judgments as potential mechanisms by which patient injection drug use affected intention to prescribe. So here we're comparing the man who injects drugs to the MSM hypothetical patient. And what we see is that both PrEP adherence and perceived responsibility of the patient seem to operate as mechanisms, such that the man who injects drugs was judged as less likely to adhere to PrEP. And therefore, because he was less likely to adhere to PrEP, that was associated with lower intention to prescribe. And for the man who injects drugs, he was also judged to be less responsible than the MSM patient, which was again associated with a lower intention to prescribe PrEP. And you see something similar when we compared the man who injects drugs to the patient who is a man having sex with women. So same pattern with respect to adherence and responsibility. Unexpectedly, we saw that the man who injects drugs was judged as more deserving of help compared with the man who has sex with women. And that was associated with a greater intention to prescribe PrEP. So I know that was a lot. So just to summarize the findings of this particular study, we saw that patient race had minimal impact on clinical decision-making, that patient risk behavior had a significant impact on providers' clinical judgments. And specifically, we saw that despite recognizing the high risk of HIV for a patient who injected drugs, providers anticipated poorer adherence and expressed less favorable perceptions of the patient. And then two clinical judgments in particular, anticipated adherence and perceived responsibility, functioned as mechanisms through which the patient injection drug use was associated with lower intention to prescribe PrEP. Okay, so now I want to turn to another study we did that was a qualitative study with PrEP prescribers, in which we kind of dug into stigma in the context of PrEP provision. So I think at this point, based on the other studies I've presented, you have the background and the rationale for why we would look at this. So I'm going to just jump right into the methods. So this study was with 18 early adopting US PrEP prescribers who were interviewed about their beliefs about stigma in the provision of PrEP, including perceptions of structural and interpersonal stigma that might interfere with PrEP access for key populations. So in terms of eligibility, again, these were individuals who are prescribing PrEP, and they were recruited through direct outreach and participant referrals. Here is the background characteristics of that sample. So there were 18 altogether, mostly male, mostly non-Latinx, kind of a mix racially, predominantly white and Asian, mixed in terms of sexual orientation, mostly medical doctors, and mostly HIV and or infectious diseases specialists. So here's a summary of the themes. And unlike with the other qualitative study where I really kind of dissected each one and gave quotes for each one, here I'm just going to present the summary of the themes from this study, but then I'll go into a little bit more depth on the one that's highlighted at the bottom there, which is views on addressing stigma. So with respect to structural stigma, participants, these providers, perceived the requirement that PrEP be accessed through a medical provider. They recognized that that could operate as a deterrent to key populations that had historically been mistreated in medicine. So in particular in the US, the Black population has been historically mistreated, and that's led to medical mistrust. They recognize that reliance on patient-initiated requests requires pre-existing awareness of PrEP by the patient, and they saw that as a form of structural stigma or potentially problematic because at the time, awareness of PrEP was observed to be more common among white MSM compared with Black MSM. So in other words, because white MSM knew about PrEP, they were asking about PrEP and they were getting PrEP. Whereas Black MSM, they didn't know about it and therefore they weren't being informed about it or having access. And then also disparate levels of health literacy and provider access disadvantages. And in this particular case, they were identifying as a disadvantage for Black compared with white people. In terms of interpersonal stigma, providers observed other providers as having biases, and particularly in relation to sexual values. So for example, knowing that other providers weren't prescribing to a patient because he was not in a relationship and they didn't think it was like morally appropriate to prescribe to somebody who was, you know, single and having multiple partners. And also biases related to sexual minority status or same-sex behavior, which would lead to avoidance of or insensitivity during conversations about sex. There were variable levels of recognition about their own vulnerability to bias. You know, some perceived themselves to be completely unbiased, whereas others were a little bit more insightful in recognizing that, like, as human beings, they are vulnerable to bias. And so that was something that they were kind of more self-aware about. When I asked about their own biases, you know, no one or very few were going to acknowledge a bias related, for example, to race. The one that came up most readily was age, and perhaps that was considered a more acceptable form of bias. But specifically, the bias that they were describing was kind of associating older people as being with being less sexually active, or describing how they might be less inclined to talk about sex with an older population. And I'll give an excellent example of that in just a moment. And I just want to clarify, when I say age is a more acceptable form of bias, that's not something that I believe, but I think that that was something that they perceived. The other form of bias that emerged was not one that they acknowledged themselves, but it came about in the interviews when they were talking about people who inject drugs. There are several instances where, you know, people were expressing biases that mirrored what we just talked about with the experiment in which we saw, you know, judgments of the person who injects drugs as being less adherent. That was the kind of bias that was coming out. When it came to views on addressing stigma, providers recommended cultural competence training and regarded it as an ongoing process. All of them thought that the training they'd had been like very much insufficient. They thought that they were culturally competent, but had acquired that competence through experience, and they thought the formal training was lacking. This provider said, I think we can always get better at issues of cultural competence. He and others perceived it to be sort of a continuous journey. Multiple providers also advocated for a standardized approach to minimize the impact of provider bias on clinical judgment. So this provider said, you have biases and judgments, your patient's gonna have biases and judgments. If you remove yours and treated every individual with a blank slate, no matter color, gender, sexual orientation, sexual practices, what they choose to say or not say, you can provide a higher level of care to that individual, especially when it comes to PrEP. And I referenced this example just a moment ago. So sometimes a standardized approach to care was prompted by an earlier clinical experience the provider had had that illuminated personal biases. So this provider offered the example of a 76-year-old white lady who came to the STD clinic, and he said, I thought, first of all, everyone thought she was in the wrong place. She said, well, I'm having this itching in my parts. I said, oh, geez, I mean, it's probably, atrophic vaginitis. Oh, that's probably hemorrhoids. Every time I gave her a solution, I'm grabbing her arm, taking her out of the room because I wasn't really about to examine her. She's a 76-year-old lady, just like everyone's grandma, very well dressed. I mean, and totally out of place. And then the third time I was going to put her out of the room, I examined her and she actually had pus coming out of her butt. She actually had rectal gonorrhea. So this provider considered his misassumptions about the patient's sexual behavior and consequent decision not to examine her to be a wake-up call. And thereafter, he implemented a more standardized approach to sexual health care for his patients. Okay, so now I want to get into just some preliminary insights from the study that I've been doing while I've been here in Australia. So in the way of background, as we all know, the HIV biomedical landscape is continuously evolving. We have new and forthcoming PrEP and ART being antiretroviral therapy modalities and dosing strategies. Also, there's evolving understanding of treatment as prevention, now as U equals U. And so this ongoing evolution presents challenges and opportunities for patient-provider communication. Certainly effective communication is essential for optimizing service delivery and ensuring equitable access to new prevention and treatment options and insights. So this study sought to explore healthcare providers' views on patient-provider communication related to new HIV biomedical options and insights. So the data were collected as part of a larger ongoing study with providers and sexual minority men with HIV living in Australia and in the US. So at this point, I've completed the provider interviews. I'm collecting data for the sexual minority men, and then I'm going to be doing the US component when I return to the US. So 1 hour interviews were conducted. All participants elected to do it by phone or online rather than in person. And so the data I'll be presenting is from 10 Australian providers. And in terms of eligibility, so they needed to be practicing in a primary care, so a GP setting and or an HIV care setting, like a sexual health clinic. And they needed to have prescribed both HIV treatment as well as PrEP in the past 6 months. Here's an overview of the sample in terms of their background characteristics. So they were mostly cisgender men, none identified as Aboriginal or Torres Strait Islander. Most were actually born outside of Australia. There was a mix in terms of sexual orientation. 100% reported having an MD or MBBS. The provider type was a mix of primary care and sexual health or infectious disease specialists. This doesn't add up to 100 because categories were not mutually exclusive. So one participant identified as both. And then on the right, you can see experience with prescribing ART and PrEP. So there was quite a range, but the median number of patients for whom PrEP had ART had been prescribed was 275. And then the median number of PrEP patients was 310. Okay, so again, I just want to give the big caveat that these are emerging themes, and these themes and corresponding quotes are based on just an initial review of the data. So systematic analysis is pending, and also I'll note that feedback is welcome. So a few things have emerged with respect to communication about PrEP. So PrEP conversations are initiated because of patient request, because of an objective risk, such as the patient having an STI, or because of the provider's perception that the patient is at risk. So none of the providers that I talked to described taking kind of a routine or universalized approach to initiating conversations about PrEP. There was consistency within providers, but not across providers in terms of the options that were offered. So what I mean by that is individual providers were consistent in the options they were offering to their PrEP patients or to their patients who are requesting PrEP. But as a patient, your options might vary depending on which of the providers that you went to. And so I'm going to give a few examples related to the type of PrEP available or offered, as well as the provider's willingness to prescribe for patients who they perceived to be at no risk for HIV. Generally, there was a lot of enthusiasm about offering new and forthcoming forms of PrEP and ART, such as injectables. Many were already prescribing injectable treatment. And there was a shared belief by many that all existing PrEP and HIV patients should be informed of new and emerging options, even though they might recommend certain ones for patients, no matter what they felt like all should know about all options. And then perceived and anticipated inequities. When I asked what they thought about, what inequities might emerge or are occurring when it comes to new forms of PrEP, generally what they highlighted were costs associated with going to see a GP. So copay, or I believe you call it gap cost or gap pay. Limited geographic access to free sexual health clinics, and language and cultural barriers. When it came to communications about U equals U, there was clear and consistent communication with patients who had HIV, but the message was not routinely communicated to HIV negative patients. So I'm going to give some examples of the themes that are highlighted in yellow. So with respect to consistency within providers, but not across providers, so providers varied in their recommendation of TAF for all patients, select patients, for example, those who are older or responded poorly to TDF, or no patients. So just to clarify, TDF is the medication, it's Truvada, it's the medication that is on the PBS, on the public benefit scheme, but TAF has been approved by the TGA, but is not available on the pharmaceutical benefit scheme. So 5 out of 10 reported prescribing TAF for one or more patient. This provider said, a large percentage of my patients actually import TAF, particularly anyone over 50. I just don't think you should be using TDF in anyone over 50 because TAF is not on our pharmaceutical benefit scheme here. Yeah, so the majority are importing, I'd say. That's probably a minimum of half of all my patients will import PrEP, if not more, really. And then by contrast, another participant said, I'm sticking with kind of Truvada, I think just to avoid confusion, just using the same one. And he specifically referenced how TDF or Truvada was the only one that was on the PBS. So in terms of consistency, again, within providers, but not across, this also materialized with respect to willingness to prescribe PrEP to an HIV negative patient in a monogamous serodifferent relationship when their partner had an undetectable viral load. So if that were the case, they wouldn't be at risk for HIV because of U=U. Nonetheless, most providers were willing and acknowledged the psychosocial benefits. So this provider said, some people still have anxiety around transmission. And so biomedically, it's not doing anything, but it's helping reduce people's anxiety around having sex that they want to have by making sure that they've done all they can to reduce or stop transmission. And so I'm happy to talk about that and definitely happy to prescribe. By contrast, there were a minority who expressed opposition, some felt quite strongly, suggesting that prescribing PrEP in that scenario was medically unjustified. And I know some of these findings dovetail with the work that Anthony has done as well. So this particular provider said, I would not prescribe it to a patient if their partner was below detection. I don't consider that an ethical use of it, regardless of whether the Australian guidelines wanted to argue that if they're really anxious, it's okay. I actually think that's crap medicine. Sorry. If someone has issues of anxiety around sexual contact, that should be dealt with by a psychologist in terms of behavioral interventions. It's not appropriate to give them a drug that's not based on treating anxiety. It provides them with no benefit and gives them potential kidney damage. So some opponents believed that PrEP, not only was it not biomedically beneficial, they thought that it could undermine the U=U message, and one mentioned that it could unnecessarily burden taxpayers. So with respect to communication about U=U, providers reported consistently discussing U=U with all of their patients with HIV. So this provider said, I will often mention transmission in the first consult because that's usually a main concern for people when they're first diagnosed. We would usually revisit that topic when somebody becomes undetectable. It's important, I suppose, to check with those patients if you don't know it's been discussed. And make sure that it has been discussed at some point. And the language they reported using was simple and unambiguous. So whereas some previous literature suggests that providers can be kind of vague and misleading when talking about U=U, using terminology such as negligible risk or virtually no risk. That was not the case with these providers. They were very clear. So as an example, this provider said, if your viral load is undetectable, then you can't sexually transmit the virus. So you can have sex with anyone you want and they won't get HIV. And then their communication was inconsistent with respect to HIV negative patients, meaning they were not consistently discussing U=U with their patients. They talked about it as being related to the patient's presenting concern. But as you can see in that top quote, it's really if the patient asks for it. And in this particular example, the patient was there for STI testing, but that wasn't necessarily grounds to raise U=U. And recognition of the need for HIV and U=U education and potentially the destigmatizing impact was there. So providers often connected those things, but it did not necessarily translate to routine patient education. And so the provider in the bottom quote really highlighted that it just wasn't realistic to inform all patients about U=U in the current health environment because of time constraints. I realize that we're running short on time, so I'm going to try to speed through this a little bit, and I apologize. When it comes to implications, so first, providers are vulnerable to social biases that could exacerbate existing disparities. So certainly providers would benefit from ongoing training related to cultural competence, including LGBTQ+ sensitivity. The current lack of evidence for training having a lasting impact on implicit bias to me begs the question of whether expecting patients to report same-sex behavior or sexual minority identity is in fact in patients' best interest, particularly if PrEP, Truvada in particular, is broadly indicated. Provider reliance on patients to initiate conversations about PrEP or U=U is problematic. It systematically disadvantages those groups less likely to know about these topics. And at least with respect to US patients, it does not meet their expectations and needs. Routinely discussing PrEP and U=U with all patients, irrespective of reported sexual behavior or identity or predicted HIV risk, can eliminate provider discretion and associated potential for bias, avoid the systematic disadvantage that I mentioned, align with patient expectations, and help to spread awareness in the community. And recognizing that providers have limited time, incorporating other educational strategies into the patient visit, such as educational flyers or TV programming in the waiting room, might be able to help. And lastly, inequities might be inevitable as long as PrEP access and U=U awareness depend on interaction with the healthcare system. Beyond provider bias, there are many other inequities. So alternative education and implementation strategies could help to circumvent healthcare system barriers. So things like broad public health messaging, investing in community-driven educational initiatives, so education coming from trusted sources in the community, de-implementation of procedures deemed excessive, and also something that there's been some talk about in the US is the notion of over-the-counter daily oral PrEP, which would just make it easier for patients to access PrEP and to circumvent a lot of interaction with the healthcare system. So with that, I will just thank my participants, recruitment partners, particularly ASHM and NAPWA here in Australia, collaborators at CSRH and Kirby, and acknowledge my funding sources. And the bottom right corner is a picture of my team at GW. Without them, none of this research would be done. So I'm very sorry that I left little to no time for questions, but I do want to leave my email address. So I would really welcome anyone to follow up with me, and I can try to answer questions that way. Thank you very much for your attention.
Thank you so much, Sarah. That was amazing powerhouse through lots of different studies with really fascinating implications. We are pretty much almost at time. Sort of some of the questions you've kind of already answered in that last part, but I wonder if you could just reflect a little bit on some of the legacies of medical mistrust in terms of racism, which is a question from Stephanie, and how you see that impacting PrEP. Access and inequities.
Yeah, so without looking at the particular question in the chat and just responding as you're saying, yeah, I mean, so medical mistrust, certainly in the US, it's a huge issue with the Black community and Black sexual minority men in particular. And so, when I'm trying to think about ways to take PrEP out of or minimize interactions with the healthcare system, make PrEP more accessible even within the healthcare system, a lot of what I'm thinking about is that group in particular, because they are the ones that are disproportionately affected by HIV. So certainly medical mistrust continues to be a problem. And sometimes we talk about it. I mean, it's important to recognize that it is a very rational reaction to historical mistreatment. And I'd also like to amend that and say it's not just historical mistreatment, it's ongoing mistreatment. A lot of the Black sexual minority men who participate in our studies talk about, very recent interactions they've had that have reinforced medical mistrust.
Great, thank you so much, Sarah. As Sarah said, can follow her up with her email. Thank you everyone for a fantastic session, and thanks, Sarah.